Amazing, amazing. Okay, this is getting close to the end of our grant planning series for digital inclusion programs in Maryland. We wanted to, at special request of OSB and some of our other members, wanted to talk about, healthcare and telehealth and things that are going on around that. So we asked Dr. Kim to present today. Hopefully I get this right. Dr. Kim is a national leader in the intersection of digital technology and health equity. Her research and community-based work focus on how digital tools and training can expand healthcare access, improve outcomes, especially for older adults. What do you think? Is that right?
Sounds good.
I'll let you introduce yourself formally. Thank you so much for coming today.
Thank you. It's my pleasure to tell you about a particular project that we have been working on for the last few years, and sort of how we started, why we were doing telehealth, how important training was as part of this project, and then what the outcomes are. And then would love to have the conversation about how this fits for for the attendees, what questions they have about trying to take an approach like this, and where we might go from here. So, as Terry said, I am Kathy Kim. I am an adjunct professor at the University of California, Davis in the School of Medicine, which is where this project started. And I'm also the founder and CEO of a company called Tequity, and our goal is to bring the best of digital health to underserved communities. And so this is work that started as a research project, and then we spun out in order to provide it to underserved communities. So, the problem that we are addressing, and I know all of you in healthcare understand this, but it really is the burden of chronic disease for people worldwide. In the U.S., we have a quarter of adults that have multiple chronic conditions, and uncontrolled. These chronic conditions are not just, complicating and a burden on daily life, but they're also risk factors for much more serious events like heart attack, stroke, kidney disease, and cognitive decline. And not only is that, a burden on health, it's also a burden on our economy because chronic conditions are associated with 71% of U.S. healthcare spending. So this is the problem that we are faced with. In 2020, when we started this project, the other thing happening in 2020 was COVID. And so we were in those conditions, unable to see a lot of patients in person. So there's been in research a number of projects where digital tools for care coordination and remote monitoring have been shown to be very promising, particularly for chronic disease self-management and care coordination. But we also know that there are a lot of challenges for communities. And these challenges are both for the individuals that live in underserved communities, such as those in rural America, those in low income areas, and those for people for whom English is not a first language. But there are also challenges for the clinics and the healthcare providers in these communities that prevent them from attaining the benefits that could be had both for the clinic and for their patients that they serve. So these are just a sampling of some of those challenges, both on the individual patient side and on the clinic and community organization side. So for patients, believe that the solution that we're offering is beneficial, how technology fits with the individual's daily life, how it fits with what clinicians are recommending that they do about their health, access to broadband, access to computing devices, access to remote monitoring devices, and then access to the services that help them to adapt technology, which we would sort of lump as digital health navigation. And for the clinicians and community organizations, they have challenges as well. They want to know, where's the evidence of the benefits of digital solutions? What are the outcomes that they might be able to see in these settings? How does it fit with the clinic workflow and the ability to efficiently manage their patients and their operations? How does data from these digital solutions interoperate with their other systems, particularly electronic health records? Where do our staff get the skills to plan, implement, and manage a digital health program? And where's the financial sustainability, right? How do we pay for this? If it's funded by a grant initially, how do we continue to pay for this program? So in 2020, when we started, this is the situation, and many of these challenges still exist today. So we built the Activate platform to try and solve this. So we bring digital care coordination and remote monitoring community health. We solve the challenges that get in the way of real world outcomes. And as I said, this was a research project initially through the university and MITRE Corporation, which is a nonprofit research and development corporation. And we did the research and then we spun out the technology after the research was completed. So our first step was to co-design with our potential users. And the reason we did that is that many of these academic papers and the research that is done are run by academic medical centers, large hospital systems, where the resources are plentiful, right? And they generally have sort of large research budgets, and they've got lots of expertise. And those programs where they might work well in large centers are not necessarily going to work in a small, under-resourced rural community. So we knew that we couldn't just take what we learned from research, and in UC Davis Health System, and just retrofit it into the community. So we started with co-design. We worked with the clinicians, the medical assistants, the operations staff, the IT staff at these clinics, and we worked with their patients and their family members and community health workers. And other members of the community who weren't actually receiving care at those health centers. So we brought together a large group of people to co-design what the program was going to be, not just the technology, but how the entire program would work, so we could address all that list of challenges we just saw on the previous slide for both the individuals and for the clinics themselves. So what did we build? Well, it starts with remote monitoring for chronic disease. We focus on diabetes and hypertension. So they wanted to use all these monitoring devices, blood pressure cuffs, glucometers, right, watches, fitness watches, scales, all of these wonderful things that are available in the market that they didn't necessarily have access to, but they knew could help people to understand what's going on with them on a daily basis. So we had them select a set of devices that they wanted to use, so any commercially available device. We developed My Activate mobile app, which automates the Bluetooth pairing between the device and the Activate system, so that when the patient uses the device, the data comes automatically to the clinic. And then we built the back end and the portal for the clinic. This is the Activate portal, which is accessed just via any web browser, where the staff and the clinicians can see the status of all their patients that are enrolled in this program, who they are, how to contact them, what is going on with them, what are the data showing, and they're coming in real time, and then being able to filter and sort people to understand who are the ones that I need to reach out to, that I need to provide some additional support, or that we need to bring in for a visit. That data then was integrated into the electronic health record system at each of the clinics. And it was made available to both the patient and to the clinic so that it could be used as part of a telehealth visit or as an in-person visit if needed, and then also as part of a health coaching program. So that is the solution. But as we said, a technology solution, a technology platform doesn't just work because you install it, right? You really need all of the wraparound services and tools to make it work in your setting, right? In this clinic setting, in this community. And so we spent more time actually working on the wraparound resources than we did on the platform itself. So the first thing you start with is what we call the digital health pathways model. And what this model does, it's actually a consultative process where we worked with each clinic separately, with their teams and their co-designers. And we said, let's map out all the steps in your program. Let's look at who does what are the actual touch points with the patient throughout the entire program life cycle. What do you want to be done and who's going to do it? So we mapped it all out. And this starts with identifying the patient, enrolling them, assessing their health literacy, digital literacy, delivering, health education, delivering technology if it's remote monitoring, giving training and assistance for people to use it, do health coaching, right? look at the data, analyze the data, assess your outcomes, and then know when a patient is at a point where they can transition back into a maintenance phase rather than active monitoring phase. So we map all of that out in great detail. And then we started building tools because at each one of these steps, some of the clinics had something in place, some of them didn't have anything in place. They're like, oh, we'd like to do more. How could we do this better? How could we, do it more efficiently? What could we add to it? And so we started building resources. So for assessment, for example, we brought to the table validated assessment tools for diabetes knowledge and self-efficacy, right? Hypertension knowledge and self-efficacy, patient activation, um, health literacy assessment, technology readiness assessment, all of those kinds of things. And then we made those available and supported them to collect the data from these assessment forms. And then to address the patient readiness, we looked at what do they know about digital health? What do they know about remote monitoring? What do they know about their diabetes and hypertension? And we started to create tools. They were handouts and flyers and infographics and short videos. And we developed these tools and then made them available for each of the sites to then customize as they wanted, add their own spin on it, right? Build it into the resources that they would use. So um, here on these patient readiness tools, on the next slide, I want to tell you just a little bit about them. And then I left our website there because we have those on our website so you can see them. So in terms of training the patients, there are a number of key principles that we really held as primary. The first is that training is about relationship building. It is not just about giving information and expecting someone to accept that information and put it into practice, but it's really about the relationship between the patient and the organization that's providing that resource. So we think of it as a relationship building exercise so that it is brought to the patient by their teamlet. So we call teamlets, the care teamlet are the people that really interact with the patient on a regular basis. Often that is a provider, so it's a physician or nurse practitioner, a physician assistant, a DO, somebody like that, supported by a medical assistant, sometimes a community health worker, sometimes some other ancillary providers. But this is offered by the teamlet that the patient knows and that the patient sees as their link to healthcare. And it's supported by the team that's prepared to offer that training and that relationship. So it's not just you provide a video and say, give that to the patient or provide a handout and give that to the patient, that they're prepared about how to deliver this information, the questions that might be asked, right? What are some of the areas that people might need additional support to be able to implement this? The second principle is that it's multimodal and that it's micro-learning. And that means that you want to deliver information when somebody needs it, which is when they're open to receiving that information, that it's engaging, it's something they actually want to look at, something they want to engage with. It's short, so it can be consumed at the point and quickly give the resource that people need. And that it's multimodal. So it's multiple languages, it's video, it's voiceover, it's text, so that people can get the information and the education in the way that they most want to receive it. The third key principle is that it's focused on the program engagement that is designed into whatever your program is. So here it was chronic care self-management. We only focused on diabetes and hypertension and people who had one or the other or both. So the content and the education is really focused on that content. Second, it's a particular and self-management of that chronic illness, right? That's a set of activities and tasks and workflows. It's Bluetooth pairing. At the time that this was implemented, we were only using Bluetooth-enabled glucometers and blood pressure cuffs and fitness watches. So everything had to start with a Bluetooth pairing of the device with our system. That was a key a technology adoption challenge for everybody. So we focused a lot on how to do that. The third is content area was the use of specific monitoring devices. So each clinic picked what are the ones that they're going to use. what was covered by the insurance, if there was any insurance coverage, what was affordable if somebody didn't have insurance coverage, and what did they have previous experience with, so they knew that, this was something they wanted to use. So it was focused on the specific devices that this clinic was going to use with their patients. And then the last piece was, what do these numbers mean, right? There's lots of chronic care self-management that's driven on, you know, um, random blood glucose measures, on blood pressure, on weight. But what do I, as a patient, need to understand about that? And what do I need to know to make a change today at this moment? So what do the numbers mean in my life right now? So those are kind of the areas that we focused on to provide those resources for the clinics to deliver to their patients. Okay. The next step was on the staff, right? The staff needed to be prepared to plan the program, to implement the program, to support the patients, to use the technologies themselves, for the staff to use the technology themselves. So here's some examples of the principles we held up for training the staff. Um, Again, it's relationship building. These staff are part of a care teamlet that is the relationship with the patient. Second, the team has to be prepared to support the patient. So the relationship building is mutual. It's patient to care team and care team to patient. So that is a key principle for both. The second key principle for the staff is about adult learning pedagogy. These are people who have jobs, who have roles in this particular program, who need to be engaged, to want the training, and to be able to apply it directly in the work that they do. So one, it has to be engaging, it has to be interactive so that it is seen as beneficial and relevant. We had to provide some of the didactic content, meaning, some of the foundational knowledge, the actual theory behind what we're doing, so that the staff had an understanding of why they were doing things certain ways. And then practical learning. How do I apply this, right? What do I do with it? It's not just sitting in a classroom and taking a quiz on it, but how do I actually apply it? So multimodal, again, we had video, we had some live lecture, we had quizzes to reinforce knowledge that had to be sort of top of mind. There's some things that you can look up, some things you just need to have on hand that you're going to be using a lot. We did a lot of role playing for people to apply what they were learning in scenarios that would come up for them in the clinic. And then for the staff to become peer partners and mentors to each other, because we might be there for a few days, maybe reinforcement a couple months later, but the learning and the reinforcement has to happen within the team. So they needed to be peers and partners and mentors to each other. So the third key principle for the staff was to, again, focus on the program role that they had. So in our program, there were the clinicians, there were the medical assistants, there were health coaches, there were digital navigators, and there were health educators. There were other folks, but these were, the primary folks that were sort of the daily contacts for patients. So the content was really focused for them. So we definitely did some foundational knowledge on diabetes and hypertension. We provided resources and sort of walking through the role of a digital health navigator as related to the functions they would provide in this program. So walking through that and having them practice those skills. We did extensive work on motivational interviewing-based health coaching, which is really key to helping the patients harness their own motivation to improve their health, right? A lot of it is not what the clinician tells the patient to do. A lot of it is what the patient decides is important for them to do, and is balanced by what they can do during their daily lives. So a lot of the health coaching is not about just giving them the rules and the guidelines and instructions, but it's really much more about using the relationship to support the patient, having them identify their health goals and the ways that they can most effectively self-manage. And then this process of training is actually part of the program design and implementation. It is not just another step that's added on. We actually did it as part of the digital pathway modeling, and we do it as part of implementation, so that in the end, every role that was part of that program comes out of it with additional capacity and additional skills. Okay. And then finally, as you go through this digital health pathway, you have engagement with the patient, whether that's virtual through telehealth, through the remote monitoring technology, through the mobile application, or whether that's in person. We have some sites that actually have mobile health vans that go out, into the community, into areas that it's hard for patients to actually travel into the clinic. And then we have patients who come into the clinic. So we needed to really plan out what are all the engagements that you're going to have and what are the different modes that you can engage with people and that the patients are likely to want to engage with you. So using this sort of very comprehensive approach is how you optimize a digital health solution to the setting where it can be most successful, in a way where it can be most successful. Okay, so we do have evidence. So we did this initially as a research project. We developed this co-designed flexible platform for remote monitoring and care coordination. These are the 4 community clinic sites where it was implemented as part of the research project. Those 4 sites are in the central area of California, which we call the Central Valley, which is primarily agricultural and rural. And it was a phase study. So we did the co-design, we did a feasibility, initial feasibility study with 50 patients. And then we called the rest of it a pilot because it was not in full production for all their patients. But then we did a pilot in each of these 4 sites as well. And then we demonstrated with its impact on outcomes. So here are the outcomes. For diabetes, we had 157 individuals across the 4 sites. They started an average A1C of 11.1, and by 6 months, they were an average of 7.5. So that reduction of 3.7 points is a really substantial reduction for these participants within 6 months. And you can see in the bar chart, the green chart is our study, where it goes down from baseline of 0 because it's the reduction in A1C. We compared it to the literature, which are the results are in the gray and the blue bars. And you can see from the literature, very few studies show a reduction of even 1. And we got 3.7 points. For hypertension, we had 116 individuals with hypertension that participated in the program. They started out at a systolic of 153 and a diastolic of 84 on average, and they ended within 6 months at a systolic of 134. So we got a reduction in almost 20 points. And again, our results are in green. For dark green is systolic, light green is diastolic. And the gray and the blue bars are what's in the literature. And you can see, again, we far surpassed what's published in the literature for similar kinds of studies. So this was co-design, including the patients and their caregivers. And so we did we had an external group do some interviewing and a qualitative evaluation. And here are just some quotes of the impact from patients. The first patient says, "I was very happy to see that someone worries about us and is checking up on the sick people. Before I signed up for this program, well, I didn't have this check-in that I have now, and that's motivated me every day to see the numbers I get. It's about relationship. This really shows it's about the relationship. Somebody cares about me. They're there for me when I need it, and they help me. And that motivates me too." I'll tell you, the health coaching visits were not every day, so I don't want you to take this to say they were talking to a health coach or medical assistant every day. The check-ins in the first few months were every 2 weeks, and then after that, generally whenever the patient wanted it. But the motivation is what lasts for the patient, right? The second quote is from another patient. It's encouraged me to change my lifestyle because prior to Activate, I checked my blood sugar. I didn't know why, but I went to the Zoom class, which is a diabetes education class that was provided. And I met with a community health worker and a medical assistant health coach, and then they put it all together in perspective to me. It just made a world of difference. It's making me want to do more. It's making me want to get better. So it's the knowledge, but giving them the perspective of why and how they can address their own goal that's made the difference for this patient. So what does this mean in terms of sustainability? So we did an analysis of how these outcomes could impact the cost to the health system. And based on published estimates of cost to the system from the kind of A1C reductions that we saw in this study, that would result in about $326 savings per member per month. For systolic blood pressure savings, which drives most of the cost of hypertension care, a 20-point reduction could lead to $191 savings per member per month. So you can get an ROI with this kind of program within a few months. This is a really substantial savings. The challenge for community health centers is they don't see the savings. The health plans see the savings, the insurers see the savings, the hospitals may see the savings because it's reductions from things like ER visits and hospitalizations. So these are not cost savings that the clinics will see, but you need the clinics to provide the services in order to get the savings for the system. So that is our project. It's how we trained. It's how we supported the communities to address the challenges both for individuals and for the clinics. And this is one of the reasons why we have spun out the platform out of the university and this R&D center to make it available to communities. So we'd love to have a conversation and talk to you about how this platform and the optimization approach could help as either further research studies for healthcare organizations wanting to improve chronic illness coordination, or community organizations wanting to integrate their services and the data that's generated from programs like this. Thank you.
Amazing. I'm
And
so
I'm
interested in the data. I don't know, my camera's not working today, sorry.
okay.
Um, yeah, so what are you doing next? What are you doing with this data? Like where are you going with it?
Yeah. So our first paper, which was on the feasibility pilot of the first 50 patients, that's already been published. And that is open access, so anyone can get that. And I'm happy to Terry to send this to you. You can distribute it to your participants.
Mhm.
The second paper, which is the full results, we're actually writing up now. We're hoping to have it done this week and submitted. And so that will be published as well. And then we have a third paper that we'd like to write which is more of like a comparative case study because each clinic did it a little differently, right? It made sense to do it differently. Different kinds of staff, different patient population, what they needed for their workflows were different. So we wanted to write this comparative case study, say, this is how each site did it. These are the differences. These are the similarities to show you don't all have to do it in exactly the same way to still get the kinds of outcomes that we saw. So that's what's next for this particular set of projects. We have, as I said, spun this out. We are providing it so we actually went live with the spun out version in January. We're serving two new health communities right now that have both been implemented. So the first one went live in February. The second one went live in April. And so we are open to providing this to communities or to research collaborators, um, public health organizations, to see if we can get it to more communities.
That's fantastic. What is the like the training look like or the support for those communities? Like what would it look like if folks in Maryland wanted to pick that up? And you could use Marylanders Online as an example or the university or a smaller program, whatever kind of
Yeah.
works for you. We would love to have like a statewide, shared metric platform. It would be amazing.
Well, we'd love to collaborate you to think about that. So as I said, we think it's really important that these training programs fit the program goals and the participants that you want to use them. So we don't really just publish, here's the training program.
Mhm.
So we'd rather, work with you to say, what are the things that need to be done? What is a Maryland program look like? And how can we build a relationship to the host of the Maryland program with the users? Because we think it really is all about that relationship and
Yeah.
supporting the relationship. So can we reuse some of the resources we have? Very likely, right? Does the program wholesale just work in Maryland? We don't know. But we'd love to see what we could reuse and how we could construct it so that it would be useful in Maryland.
Absolutely. I love it. Yeah, we're focused on, similar things, not necessarily in health, but just trying to collaborate, and we're rolling out our digital navigation training modules. So that would be fun to partner too. Because we really would love to train more community health workers around digital navigation and digital inclusion. So
Yeah, absolutely. I mean, that is, I think the health coaching and the digital navigation are really the navigators. Those two roles are so critical. They are the relationship. I mean, healthcare is provided by the clinicians. So we're not delivering healthcare, right? The clinicians still deliver healthcare. But the digital inclusion, the digital literacy, a lot of the health literacy support is from these two roles because that's who people trust. It's who they interact with to ask the questions, to get the help. They might still, those two roles might still need to go to a clinician or a health educator or, nurse care coordinator or somebody else to get the content, but it's the relationship that gets the patient asking for the help.
exactly, and everything, right? It's
Hmm.
that, how do we support the folks on the ground helping the patients, the folks with the trusted relationships? We have some questions in the chat. Julie, I don't know if you could read those. I can't see them today.
Absolutely, happy to.
Yeah,
So the
thanks.
first one is, was telehealth in the sense of virtual appointments with providers outside of monitoring part of the project, and how did that work?
Yeah. Yes. And again, it was different in each site, which is why we said we want to do this sort of case study comparison. So in one of the clinics, they had implemented a very early kind of telehealth, trying to use WebEx links. And you can imagine how well that went in 2020. And they were like, oh, this is just not working. And then they ended up buying a patient engagement platform that they implemented in early 2021 that integrated telehealth through a mobile text message, right? And you click on the link and then it launches a telehealth session with the clinician. So we were a complement to that system. So they didn't have to come through Activate to do that telehealth visit. That was built in, it was integrated to the EHR and the EHR scheduling system. So we are complementary to that. The three other sites did not have any virtual visits. They tried, and it didn't work. The populations in these three other health centers were even less ready to do any kind of telehealth in this first site. The first site, the patients were a little bit more ready. In these other sites, there was just no ability to do that. So they did not do telehealth visits. They only did audio. I mean, I guess audio visits are telehealth visits. So they only do telephone. They didn't do any video. But interestingly, because one of the things we were able to provide was tablets and data plans for at least a subset of the patients. We didn't have funds for everybody, for a subset of patients. One of the things they were able to do with the tablets was to load the patient portal onto the tablet and say, hey, when you're ready, when you want to, click on that icon. We'll help you learn how to use the portal, right? So it does have some spillover effects in ability at least to get on the portal and things like that. But which is obviously a form of at least digital health information access, if not telehealth.
Wonderful. I have a great one from John Owen for the Library for the Blind. Did you have any patients who were blind in the study? Curious about how accessibility for this population was incorporated into the platform.
Yeah, we did not have anyone who was blind or hearing impaired. At least the clinics did not tell us that anyone was blind or hearing impaired. So we don't know ourselves because we didn't enroll them and we didn't ask for that kind of information. I will tell you that we think hearing and vision impairment are really major issues for underserved populations, for older adults, even not even older adults, middle-aged adults. Hearing loss and vision loss starts to happen around age, in the 30s. So your function just starts to degrade. So we think it's a really major issue. we actually have a proposal that we have submitted to create an entirely voice navigated version of the mobile app so that someone who has at least vision loss or vision challenges could interact just by voice and navigate everything by voice. So not just reading the content, but actually launching the functions in the mobile app just using a voice interface. So we would love to work on that, but we've got a proposal in. We don't, who knows with funding these days, but we definitely think that's important. Language access is also an issue. So we did have a lot of resources. If you go look at the videos that I gave on that on our website, we had them animated videos narrated in English and Spanish, and then closed captioned in Hmong and Punjabi, which are the two most common languages after English and Spanish in the Central Valley area. So we did try to address those language needs. I will say the entire software program was not in all those languages, though. So we're working on expanding the language ability, the language of the delivery of the software, at least in multiple languages, but more work to be done there.
Thank you so much. I have another one that says, who are the biggest champions who helped to influence or lead, or what kind of leadership was available to make this happen at different sites?
The center CEO or executive director, that was the critical person who had to want this. So in each of the 4 research sites, actually in the 2 new ones as well, the engagement started with the CEO or executive director who had a vision, right? The vision has to be, we think digital health is important and we see how it could help us and our patients. That motivation has to be there. The second important person is a clinician. Whether it's the medical director or, one of the clinicians, somebody clinically has to say, I'm willing to stand up for this and I'm willing to be the guinea pig. Because if you don't have a clinician and their teamlet willing to do it, it's not going to go. You can't just say, okay, this is a medical assistant run program, right? It's got to be integrated with the care. So a clinician champion was the additional person. We didn't always start with the clinician champion. We always start with the executive director. And they often brought in a couple of clinicians to, vet this program and to think about it. And somebody on the clinical side had to stand up and said, I'm willing. I want to do this. So that was the other important thing. Often the staff and, operational folks, IT folks will come along if those 2 leaders say this is important for us to do.
Wonderful. Thank you.
What
Lots of, oh, go ahead.
I want to take that a little further in terms of buy-in, maybe from departments of health, or like, are you seeing kind of more regional or statewide initiatives of this sort?
Yeah. I'll tell you what, so our implementation in Hawaii is a regional one, and it's run by it's the Hawaii State Rural Health Association. And so there we don't, that's our client, that's our partner. They're engaging with other community health centers, they're engaging with the Department of Public Health, they're engaging with other nonprofit organizations. And there is a great deal of interest from a larger stakeholder group beyond the association itself that's running this project. And they've told me they're getting lots of interest, people calling them saying, hey, can we expand this? How can we get involved? What can we leverage from what you're doing, what you're learning? So there's quite a bit of interest. We're not out there just marketing to public health departments and things like that. But for your attendees on the call, if this is something you want to pursue, or you have, partnerships or, stakeholders that you engage with that want to do something like this, we would be there to support you in doing that.
Thank you. Thank you so much for sharing your knowledge so generously. Some really great feedback in here. I'm going to scoop back up to the top because I think I missed one. And you might have already touched on this. Are you able to share the cost of the research program, including staffing numbers and how the study was funded?
I can tell you that it was funded by a donor. I can't tell you who the donor was or how much.
Oh, come on.
We've been asked to keep that confidential. That was the funder's request, which I think is lovely. They're willing to fund it, but they don't want anyone focusing on them. So they asked us not to say how much it was or who they were. So the research was funded by a donor to the university. In addition to that, there, some of the costs are borne by insurance because, during the public health emergency, funding of remote monitoring devices did happen in some states and from some Medicaid health plans and others. So some of the costs started to get covered by insurance. So I would consider that funder for the project because we didn't have to have grant funds to do all of that. So there are different sources. In terms of staffing, not of the research team, but of staffing of the program at the clinic, maybe, I don't know. There was at least one clinician with their own teamlet. And often, in health centers, it's like a physician or nurse practitioner or physician assistant with two medical assistants. Is kind of a teamlet. And so you would want at least one of the medical assistants to be the support person, and then usually a shared community health worker. So in the biggest implementation, which was about 200 patients, they had a half-time MA and a half-time community health worker for the full year that did everything from the managing the co-design with us, to all the focus groups and all that, to actually testing everything, to implementing it, and then supporting the patients throughout the year. So the support from the staff was, as I said, for a pretty large program, can be fairly minimal.
Thank you.
More?
I don't say. Let me know if I'm missing any here, but we have some time. So if anyone even wants to take themselves off mute and maybe ask questions, or if you have anything you'd like to share, we have some time for that.
Does anyone here have anything similar or addressing similar issues in their local programs that they want to share with this group? The series, kind of started so we could all have some inspiring examples and opportunities to connect around, just what comes next for Maryland and the Maryland digital equity ecosystem. So we're really trying to, use this to gauge, what's happening and what the gaps are, aside from our regular, asset mapping and needs assessments, but especially in this time where everybody's pivoting to really hyper focus on our collaborations and our partnerships and the programs that are out there that we can connect with and we can kind of win-win. And our goal at MDEC and Marylanders Online is to support those folks working. So with our digital navigator training, our practitioner work groups, all those kinds of things. So yeah, if you're listening, if you're on this call and you have a local program you want to chime in, that would be amazing. I had another question of kind of about the post of this project and what happens after the that's really big on my mind right now. Like what happens when these grant funds end, I mean, I know like funding sustainability and this and that, but like what happens to the people in the cohort? What happens to, how do you offboard them, or do you?
Yeah. Yeah, so there in that last step in the digital health pathway is the transition to maintenance step, because we know with chronic illness, you're generally not cured. You're going to have it for the rest of the year and the rest of your life. And the goal is to manage it well so you don't get complications or worsening of your condition, but you're really probably not going to get cured. So it's always a transition to maintenance. And what that means is that people will hopefully stay engaged with the clinic, stay engaged with the provider, come to their regular checkups as needed, do their regular, health maintenance activities. But it may mean that they don't have to keep using the monitoring device all the time, right? We know it's also your condition goes up and down, and things in your life change, and so it may be that they don't monitor a lot, after 6 months. But if they come to their annual appointment and you see that their numbers are starting to get a little out of whack again, you can say, hey, why don't you try monitoring again for a week or so and see what's going on? Let's talk about how what's happened in your daily life that you might want to address. And so it's a transition to maintenance because you keep the relationship. One of the things that we heard from probably the most active health coach was that she was so shocked by how the patients in this program started to see the clinic as their clinic. as their team rather than somewhere I have to go. And she would often get messages from them saying, "Hey, I'm going on vacation for 2 weeks, so you might not hear from me in 2 weeks, but don't worry, it's because I'm on vacation." So people were proactively like telling the clinic what's going on in their lives, the good things and the bad, right? And so she said it just helped the whole relationship, right? And that you don't want to lose that relationship. You want to still have them feel that this is their clinic. So, so I think that that probably does persist, although we're not tracking that, we're not measuring that. I would hope that that would persist. One of the clinics that we're working with right now was also in the pilot, and they have continued, and their focus is on enhancing their ability to bill, right? Some of these services are now billable to Medicare at least, and some to Medicaid, depending on your payer. But they are billable to Medicare. They've not had the infrastructure before to bill. And so part of this launch of this phase is to for us to get the data in the EHR so that they can create bills for Medicare. And so that's part of the goal of this project this year, to track. Were they able to get the billing done? How much has it affected their income? Can it sustain the program? Those kinds of things.
That's awesome. Yeah, building in a funding mechanism or at least some kind of catch, right?
Absolutely.
Let's see. I think you covered Jim's question. Are these programs covered by health insurance, specifically Medicaid and Medicare, including the device acquisition piece?
Depends on, well, Medicare it is. And it depends on the condition, obviously. It's not every remote monitoring device for every condition, but for diabetes and hypertension, generally, yes. For Medicaid, it completely depends on your state plan and if you have Medicaid HMOs, what they decide to cover.
Awesome. Let's see, Kat said, right? It's about personal touch. And although AI or tech has enabled us to do so much, it has really put a dent in making someone, whether it's about health or not, or in talking to someone, whether it's about health or not. Yeah, we talked a lot about this, like the tool and, using AI. And have you guys, that's a great question for you. Have you implemented AI, in the platform? And do you tell people that you I was at the doctor's this morning and they come
Oh
in and they're
gosh.
like, I'm using this blah 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 and the note-taking tool, right?
Yeah.
And so we talked about it because I'm interested in AI policy and she said, I do think it's intentional not to use the term AI, right, when they say
Yeah.
that, because it's such a trigger word, but
Yeah.
anyway, carry on.
So I love this comment because what we call it is digital first, but not digital only. So in our platform, we did everything to make everything run digitally if you can, but it doesn't mean that that's the only way that you interact with people, because that relationship is so important, and the technology can be great and fail because you don't have the relationship. And it can be bad and succeed because you have the relationship. So we really think it's digital first, but not digital only. In terms of AI, right now on the platform, we don't have any AI running the platform or running the engagement. We we are working on AI, but as a separate project. So we were funded at the beginning of the year to create what's called a digital twin. And
Yeah, that's
Yeah, so a digital twin is a virtual representation of a physical entity, whether it's an organ or it's a machine or something. And so when you have a virtual, computer representation of it, you can interact with that like a simulator. Like, so if you have a heart, right, you have a virtual simulation of a heart. Somebody practicing a procedure, surgery, can interact with the virtual simulation, but the way they actually do it, the way they cut, the way they, hold things is interacting with the simulation in as if it's real life. So it reacts to what you as the user are doing. That's a digital twin. So it has to have an interaction with the physical world. So our digital twin is looking at older adults in community-based settings who have diabetes and hypertension. And what we're modeling is how their disease will progress over time. And predicting if you did a certain intervention at a particular time point, how would it change the trajectory of their disease? Does it get better? Does it get worse? How much better or worse? When does it get better or worse? And then does that result degrade over time? Do you now need to do something else at some other point, right? Because chronic disease will last for the rest of your life. So it's about the trajectory of your disease and predicting when and where and for whom those interventions are best placed. So that's our AI. To me, the reason it's related to Activate is if you don't have data for the people in underserved communities, you will never have them in your digital twin model. You will never have them in your AI prediction models. And we know that most AI, clinical AI in healthcare, is done using databases from large academic medical centers. That's what the data that's available. We think it's really important that the data we're bringing to the table is from underserved communities and can be used, of course, with approval. So we only use it when we have a data use agreement that's signed with the clinic, that they know how we're going to use the data, we're going to de-identify it, all those things. So we only use data when there's a use agreement for us to do that. But we think it's really important to represent, rural communities, underserved communities, older adults, in this AI development. And that was funded by National Institute on Aging and part of NIH.
Yay. Let's see. We have a couple more questions. I'll throw them out and then
Oh, I
Julie
should say one
usually.
other thing.
Oh yeah.
Multi-language thing.
Mhm.
Sorry, the voice navigation thing that I said.
Mhm.
You've got to be able to navigate, for people who are vision impaired. Um, you to be able to navigate software by voice. That will require us to use AI.
Oh yeah, that makes
So
sense.
we'd love to develop that, and I think ethically you need to tell people that that's what you're using. But you need to
Absolutely.
describe it in a way that makes sense to them. Like people think AI is just one thing. We know that it's not just one thing. So we have to be able to describe it in ways that people understand and understand the impact and the choice they're making. Not
Yes,
just a
and how
massive
it
user agreement.
benefits or what the risks are. Yeah.
Exactly.
And
Exactly.
it will be so it'll be multilingual at that point, right? Which is the purpose of using AI, right?
That's right.
For yeah. Okay, great. Let's see. I'm gonna read these two questions and then Julie can do our wrap up because she's so good at it. But Bori says during research, how did you get the patients to buy into the program? Were they asked during their visits, post-visit survey, mailers? How were they selected?
Yeah. So the clinics did all the outreach. We didn't do any of the outreach, but we provided a flyer, an FAQ, the videos. We actually had the primary clinician record his own video, so that they could give that to the patients. We helped develop all the resources for the outreach, but the medical assistant and the clinicians team did the outreach. For the most part, they did a pull of records from the EHR or from the data warehouse for patients who were eligible. And then they sent a letter, or in one case, they actually had an SMS system already set up for patients because of COVID. And so they sent out a text message saying, we have this program, would you like to learn more? And we will either send you it, by text, or we'll mail you the information. So it was primarily done as proactive outreach based on the list. They did, once they kind of finished that, then they started moving, when they started having patients coming back into the clinic, then they moved to also offering it to patients who came into the clinic that were eligible. So in person as well.
Awesome. And were there like caps on how many folks, or did you just take anybody who wanted to do
Yeah,
it?
we had a cap for each site. Like they set a target for themselves what they thought was useful and how many they wanted to be able to serve within a certain time period. So they each set a cap themselves. It wasn't us.
Nice.
And then they committed to that amount, and all of them they all reached their targets. So it was pretty successful.
This is incredibly inspiring. We have a lot of great questions. I'm going to read this one, and I think it's a good one to go out on. It says, so the target healthcare provider customers are local clinics within hospital or standalone like ER clinics, or do you see major hospitals as potential customers or major healthcare providers even as like United Healthcare, Humana or something?
I think insurance companies could be customers, right? They could say, yeah, we'd like to offer this in X number of regions, or X number of clinics, or particular provider networks. So I think insurance companies could clearly be customers. Um, academic medical centers, large hospital systems could be customers. I think many of them have access to solutions like this already themselves or can build it. I mean, ours is already built, so of course we'd love everybody, to use this and buy it and all that kind of thing. But I think many large organizations already have the resources to do this. And so they're not who we're actively pursuing. But if, you came to me and say, hey, I have a hospital system that wants to do this, we would do it. Certainly, we'd help you do that. But where we want to focus our limited resources, we have a very small team, is going directly to underserved communities that need it, through whatever channel they have. It may be sponsored by a hospital or insurance company or public health organization or something like that. But we would certainly offer it to others if there are people who want to reach that same goal.
That's amazing. I think it's a perfect complement to our digital navigator training, and we have the same target audience, I guess, or target customers. So that's fantastic. Let's see. I can't stop this conversation. It's so good. Um, Robin says, I've just reached out to one of our hospitals' chief digital health officer to set up an informal session with our library patrons. That's great. It's perfect. All right.
I did send you all handouts with copies of the
Great.
slides, and my email is in those slides as well, so you can distribute that. And I'm happy to talk with people if they're interested in any
Yeah, same
follow-up.
here. We should definitely set up a time moving forward to get
Very
together and
good.
talk about our two programs.
Yeah.
Julie.
Hi. Thank you so much, Dr. Kim. That was wonderful. And this is such a poignant and relevant topic right now. And I definitely think I'm excited to take this back to a couple of the coalitions I serve on, specifically in the Midshore, where we're trying to figure out ways to better empower and connect, our rural communities to these services. So really great. And I will be following up after this with Dr. Kim's presentation. This session will be uploaded onto YouTube, so definitely subscribe. I added all these links in the chat. This is the second of the last two sessions of this webinar series, so we hope you'll join us tomorrow for our final session. That's going to be on program evaluation and shared metrics tomorrow from 1 to 2 p.m. Eastern Time. Feel free to register there. Link is in the chat, and share it with any of your networks who might benefit from this. And then finally, every Friday for the rest of the month, including the 26th, which is a Thursday, we are going to be hosting the 2025 Empowering Health webinar series. And we have some really great topics related to health equity, telehealth, and empowering communities through digital technology. So we hope you'll join us for those as well. But otherwise, I wish everyone a very happy Wednesday. Enjoy the rest of the week. Thank you, Dr. Kim, and we will see you soon.
Do the survey.
And do the survey. Thank you.
There's a
Thank
QR code
you.
in the chat.
Yeah,
Thanks,
it's in the
Dr.
chat.
Kim. Thank you.
Awesome. Thanks. Take care,
That's
everybody.
great. So good.
Bye.
Bye.